Welcome to the Hospital Medicine Unplugged podcast. Today we're doing a deep dive into, well, one of the most common things we see, right? Atrial fibrillation. Specifically, we want to focus on how we manage it now based on the latest evidence, especially for the patient who's actually in the hospital.
Yeah, it's definitely a dynamic field. And managing AF in the hospital, it really requires quick thinking, but also a structured approach. Following the guidelines, the big ones, ACC, AHA, ACCP, Heart Rhythm Society.
Right. And when you break it down for someone on the wards facing this acutely, it seems like there are maybe three core things to think about.
That's a good way to put it. Three pillars, essentially. First, you absolutely have to find and treat any acute triggers. What set this off now? Second, that big decision point. Rate control or rhythm control? Which path do you choose for this patient? And third, which is crucial, is anticoagulation, preventing stroke. That has to be front and center.
That framework makes sense. Identify triggers, pick a strategy, prevent clots.
Exactly. But layered over all of that, the absolute key principle, and sometimes this gets missed in the rush, is individualization. You just can't use a cookie-cutter approach. Every single decision needs to be tailored.
Tailored based on what specifically?
Well, based on their immediate hemodynamics, are they stable or unstable right now? Then their comorbidities. What else is going on? Because often that's why they're in the hospital. And then fundamentally balancing those risks. The stroke risk, using the CHADS-VASc score, against the bleeding risk, which we think about using the Hasbled score.
Okay, that makes sense. Individualized based on stability, comorbidities, and that stroke versus bleed risk calculation. Maybe we should start just briefly with the absolute basics. What is AF, electrically speaking, and what do we absolutely need to see on that ECG strip?
Sure. So electrically, AF is a supraventricular tachyarrhythmia. Fundamentally, it's chaos in the atria. Uncoordinated, super fast electrical activity. This means the atria aren't really contracting effectively. They're more just quivering. You lose that atrial kick.
And on the ECG, what are the non-negotiables?
Two key things you must see. First, the ventricular response has to be irregular. The R-to-R intervals are completely random. Second, you won't see distinct P waves. They're gone. Instead, you see these low amplitude, often high frequency fibrillatory waves. Oh, and importantly, the guidelines say an episode needs to last at least 30 seconds to officially call it AF.
Got it. Irregular, no clear P waves, just fibrillatory waves, and at least 30 seconds. And that duration, that leads us into how we classify it, right?
Right.
Which then influences the long-term plan.
Exactly. The classification is based on how long it lasts. So paroxysmal AF, these are episodes that stop on their own or maybe with an intervention within 7 days, usually less. If it lasts continuously for more than 7 days, or if it needs something like cardioversion to stop it after that point, we call it persistent AF.
Okay, paroxysmal is short, persistent is longer than a week.
Right. Then there's long-standing persistent AF. That means it's been continuous for over a year. And finally, permanent AF. Now, this isn't about duration per se. It's actually a treatment decision. It means the patient and the clinician have mutually decided, okay, we're not going to try to get back to sinus rhythm anymore. We're accepting the AF and focusing on rate control and stroke prevention.
That distinction for permanent AF is important. It's a decision, not just a duration. And the scale of this is huge, right? But why are hospitalized patients specifically so much more prone to developing new AF?
Oh, the numbers are truly staggering. It's the most common sustained arrhythmia we deal with. Over 10 million adults in the U.S., and that's climbing because our population is aging. Age is a huge factor, along with chronic things like hypertension, obesity, diabetes, sleep apnea. These all set the stage.
But the hospitalized patient,
right. The hospitalized patient faces this perfect storm of acute triggers. Think about sepsis or any major infection, big surgery, an acute MI, pneumonia, or a PE. All these things cause massive inflammatory stress, huge autonomic surges, and that can really tip a vulnerable atrium into AF.
Let's talk about that vulnerability. What's actually happening in the atrium pathologically that makes it susceptible? If the chronic conditions build the stage, what does that stage look like?
It's about creating what we call a vulnerable atrial substrate. This happens through atrial remodeling. There are really two main parts to this. First, structural remodeling. You get fibrosis, scar tissue building up. The atria can dilate, get stiffer. This disrupts the normal electrical pathways. Second, there's electrophysiological remodeling. Changes the ion channels in the atrial cells themselves. This can shorten the refractory period, making the tissue more excitable, more likely to sustain those chaotic reentry circuits. And then you have chronic autonomic nervous system dysfunction kind of overlaid on all of this.
Okay, so the tissue itself changes structurally and electrically. Where does the initial spark usually come from, especially in those early paroxysmal cases?
Yeah, the trigger. In the paroxysmal stage, the leading theory is that it often starts with ectopic foci. These are like irritable clusters of cells, and they're most commonly found in the sleeves of atrial muscle that extend just a little way into the pulmonary veins. These cells can fire off really rapidly and chaotically, kind of hijacking the rhythm from the normal sinus node.
So pulmonary veins are key for the start, often.
Mm-hmm.
But does that change as AF becomes more persistent?
It does, yeah. As you progress from paroxysmal towards persistent or even permanent AF, the thinking shifts. It becomes less about those specific pulmonary vein triggers initiating it and more about the remodeled atrial substrate perpetuating it. The whole atrium is diseased, essentially, and it's capable of sustaining the AF on its own, even without those initial triggers.
And that progression isn't just a label change, is it? It has real clinical consequences.
Oh, absolutely. Progression is bad news. Moving from paroxysmal to persistent AF is clearly linked to worse outcomes. Higher risk of developing heart failure or making existing heart failure worse, a significantly higher stroke risk, often quoted as 4 or 5 times higher than someone without AF, and just generally higher cardiovascular morbidity and mortality. This progression really underscores why some of the newer strategies are focusing on intervening early.
Okay, let's shift to the bedside then. We suspect AF diagnosis often starts with symptoms, but we know it can be sneaky. What kinds of symptoms should make us think AF?
Right, the presentation varies hugely. Some patients have classic palpitations, that feeling of a racing or irregular heartbeat. Others might feel shortness of breath, maybe profound fatigue they can't explain, sometimes dizziness or even syncope. But, and this is a huge clinical point, up to maybe 40% of patients are completely asymptomatic. They feel fine, which is why screening in high-risk groups, older patients, those with hypertension or heart failure, is becoming more important.
And once we've confirmed it on the ECG, how do we grade how much it's affecting the patient?
We use the EHRA classification, that's the European Heart Rhythm Association score. It grades the symptom burden. It goes from EHRA 1, which is no symptoms at all, up to EHRA 4, where the symptoms are disabling, really interfering with daily life. And this score is actually really important because it helps guide how aggressive we should be with rhythm control. You probably wouldn't push for risky antiarrhythmics in someone who's EHRA 1 feeling perfectly fine.
Okay, so EHRA score helps tailor the symptom management part of the strategy. Once confirmed, arguably the most critical next step is figuring out their stroke risk. Let's quickly run through the CHADS-VASc score components and the threshold for action.
Absolutely critical. CHADS-VASc is the standard tool. So C is for congestive heart failure history, H for hypertension, A for age 75 or older gets 2 points, D for diabetes, S for prior stroke or TIA, that also gets 2 points. Then V for vascular disease like prior MI, peripheral artery disease, aortic plaque. A for age, again, 65 to 74 gets 1 point. And SC stands for sex category. Female sex gets 1 point.
And the threshold. When do we generally pull the trigger on anticoagulation based on that score?
The guidelines are pretty clear. For men, a score of 2 or higher means anticoagulation is recommended. For women, it's a score of 3 or higher. At those levels, the estimated annual risk of stroke generally starts to outweigh the risks associated with taking an oral anticoagulant.
But stroke risk isn't the only calculation. We also need to think about bleeding risk, especially when starting anticoagulants. That's where has-bled comes in.
Exactly. The has-bled score helps us estimate the bleeding risk and, importantly, identify potentially modifiable risk factors. So H is for hypertension, specifically uncontrolled systolic 160. A for abnormal renal or liver function, 1 point for each. S for prior stroke, B for bleeding history or predisposition, L for labile INRs if they're on warfarin, E for elderly, meaning over 65. D for drugs or alcohol use concomitant NSAIDs or antiplatelets or heavy alcohol use count here.
And how should we use that score? Does a high score mean we don't anticoagulate?
That's a really important clarification. No, a high has-bled score does not automatically mean you withhold anticoagulation if their CHADS-VASc score indicates it. What it does mean is that this patient is at higher risk of bleeding, so you need to be extra careful. It flags them for closer monitoring. Maybe you need to be more aggressive about controlling their blood pressure, stopping those NSAIDs, counseling about alcohol. It really informs how you manage the anticoagulation and what precautions to take, rather than being an absolute contraindication itself.
Got it. Has-bled identifies risk and guides vigilance, doesn't necessarily prohibit treatment. Okay, let's pivot to the acute management. Patient hits the floor, new AF, or maybe their chronic AF is suddenly rapid and causing issues. Before we even think about drugs like beta blockers, what's step 1?
Step one, especially in the hospital where AF is so often triggered by something else, is hunt for and fix reversible causes. This is absolutely the lowest hanging fruit and often the most effective thing you can do. Are they septic? Get antibiotics going. Manage the infection. Are they hypoxic? Optimize oxygen. Electrolytes off. Fix them. Acute heart attack. Address that.
You mentioned electrolytes. Which ones are the big players here, and what levels are we aiming for?
The two main culprits are hypopotassium and hypomagnesemia. They're notorious for triggering AF. We generally aim for a serum potassium level above 4.0 milligrams per liter. And for magnesium, the target is usually above 2.0 milligrams per deciliter. Just aggressively repleting potassium and magnesium, especially if they're on diuretics or have GI losses, can sometimes be enough to flip them back into sinus rhythm spontaneously. You might avoid needing any rate or rhythm drugs at all, particularly in, say, a post-op patient or someone critically ill where it's clearly just a stress response.
Okay, so always check and correct K and MAG first. Once we've addressed any obvious triggers, the pathway really splits based on whether the patient is stable or unstable, right? What defines instability here, and what's the immediate action?
Right. Stability is the critical branch point. Hemodynamic instability means immediate decisive action. Instability looks like hypotension, signs of shock like cool extremities, altered mental status, poor urine output, or acute severe heart failure like flash pulmonary edema that's clearly driven by the fast heart rate from AF. In those situations, you don't have time for meds to kick in. The mandatory intervention is immediate synchronized electrical cardioversion, DCCV. Get them back in sinus rhythm now to restore perfusion.
So unstable equals electricity, no messing around with IV drips first.
Exactly. But for the patient who is stable, maybe tachycardic and symptomatic, but blood pressure is okay, no signs of shock, then we have time to think about medical management. And usually, the initial focus here is on controlling the heart rate.
Rate control first for the stable patient. What are the go-to agents in the acute setting?
The first-line agents are usually IV beta blockers or IV non-dihydropyridine calcium channel blockers. For beta blockers, think IV metoprolol or maybe esmolol. Esmolol is great in more tenuous situations or the ICU because it has an ultra-short half-life, wears off in minutes if you cause problems. Metoprolol is a good workhorse for the floor. The calcium channel blockers are IV diltiazem or verapamil. They work very well for rate control, too.
Is there a reason to prefer one class over the other?
Yes, absolutely. The key is comorbidities. If the patient has known CAD or especially HFrEF heart failure with reduced ejection fraction, beta blockers are strongly preferred. They have proven benefits in those conditions. You absolutely want to avoid the non-dihydropyridine calcium channel blockers, diltiazem, verapamil, in patients with HFrEF because they have significant negative inotropic effects, meaning they weaken the heart's contraction, which can be dangerous in systolic heart failure.
Okay, beta blockers for HFrEF or CAD. Calcium channel blockers are okay otherwise, but avoid in HFrEF. Now, for decades, rate control was really seen as the main strategy based on some older landmark trials. Can you remind us of that history before we talk about the newer evidence?
Sure. The thinking was really shaped by trials like AFFIRM and RACE, published back in the early 2000s. These studies compared a strategy of rate control, just keeping the heart rate down, versus a strategy of rhythm control, trying to restore and maintain normal sinus rhythm, mostly using the antiarrhythmic drugs available back then. And what they found, broadly speaking, was that there wasn't a significant difference in major outcomes like mortality or stroke between the two strategies in the overall population studied.
So the conclusion was, why bother with potentially toxic rhythm control drugs if just controlling the rate works essentially just as well for the big outcomes?
Exactly. That became the dominant paradigm for quite a while. Rate control was seen as simpler, safer, and non-inferior for survival and stroke. Rhythm control was reserved mainly for patients who remained very symptomatic despite adequate rate control.
But that whole picture has really been challenged recently, hasn't it? Especially by one major trial, EAST-AF-NET-4. This seems to have caused a real shift.
Yes, EAST-AF-NET-4 was a game changer, a true paradigm shift. The crucial difference from the older trials was the timing. They enrolled patients with early AF diagnosed within the previous year, and they compared standard care, which was mostly rate control initially, to a strategy of early and comprehensive rhythm control, using either modern antiarrhythmic drugs or catheter ablation.
And what did they find? Why was it such a big deal?
The findings were pretty striking. Early rhythm control was found to be superior to standard care, and superior not just for symptoms, but for hard cardiovascular outcomes.
What outcomes specifically?
The primary outcome was a composite of cardiovascular death, stroke, or hospitalization for worsening heart failure or acute coronary syndrome. And the early rhythm control group had a significant reduction in this composite outcome, about a 21% relative risk reduction, with a hazard ratio of 0.79.
Wow, a 21% reduction in major events. That's substantial.
It is. And maybe the most revolutionary part was that this benefit was seen across the board, even in patients who were asymptomatic or minimally symptomatic, those who were EHRA class 1 or 2. This really suggested that actively controlling the arrhythmia early on, even if the patient feels okay, might prevent the long-term negative consequences of AF, like atrial remodeling and progression to heart failure or stroke. It reframes the goal from just symptom control to potentially disease modification.
That's a fundamental shift. Treating the rhythm itself to prevent future badness, not just waiting for symptoms. So based on East AFNet4 and other data, how do we now decide between rate and rhythm control? Who still gets rate control primarily?
Okay, so it's still a nuanced decision, needs to be individualized. Rate control is still generally preferred for patients who are truly asymptomatic or have very minimal symptoms, maybe EHRA 1 or low 2. Also, for patients with very advanced age, significant frailty or sarcopenia, or those with really severe irreversible comorbidities like end-stage lung disease, or maybe certain infiltrative cardiomyopathies like amyloid, where the risks of rhythm control strategies might outweigh potential benefits. And of course, it's the strategy for patients who are in permanent AF by definition.
So asymptomatic, elderly, frail, severe comorbidities, or permanent AF lean towards rate control.
Generally, yes. The goal there is mostly symptom prevention and avoiding tachycardia-induced cardiomyopathy.
And who should we be strongly considering for a rhythm control strategy now?
Rhythm control is definitely favored, even recommended, for patients who have significant AF-related symptoms, so think EHRA class 3 or 4. They feel bad because of the AF. Also, based on East AFNet4, any patient with newly diagnosed AF, especially if they have other cardiovascular risk factors, should be considered for early rhythm control. And a really important group is patients with heart failure, particularly HFrEF.
Right, let's focus on that HFrEF interaction. AF and heart failure with reduced ejection fraction often go hand in hand. Why is rhythm control so important there?
It's often a vicious cycle, right? AF can worsen heart failure by causing rapid rates and loss of atrial kick, and heart failure itself promotes atrial remodeling that leads to AF. For patients with HFrEF who are symptomatic from their AF, restoring and maintaining sinus rhythm can provide a significant benefit. The CASTLE-AF trial really highlighted this.
Tell us about CASTLE-AF.
CASTLE-AF specifically looked at patients with HFrEF and symptomatic AF. It compared catheter ablation, a definitive rhythm control procedure, versus standard medical therapy, which was mostly rate control but could include antiarrhythmics. And the results were pretty dramatic. Catheter ablation led to significantly lower rates of death from any cause and fewer heart failure hospitalizations compared to medical therapy. It also showed improvements in ejection fraction and quality of life. So for symptomatic HFrEF patients, there's strong evidence that pursuing rhythm control, preferably with ablation, improves major outcomes.
That makes ablation almost first line for symptomatic HFrEF and AF then?
It's definitely strongly considered as a primary strategy in that specific group, yes.
And briefly, what about HFpEF heart failure with preserved ejection fraction? They often rely even more on that atrial kick, don't they?
That's a great point. In HFpEF, the problem is often diastolic dysfunction. The ventricle is stiff and doesn't relax well. These patients are very dependent on that organized atrial contraction, the atrial kick, to adequately fill the stiff ventricle. Losing that kick with AF can drastically reduce their cardiac output and make their heart failure symptoms much worse. So arguably, restoring sinus rhythm might be even more hemodynamically important for symptomatic HFpEF patients. Although we have less robust trial data specifically for ablation outcomes in pure HFpEF compared to HFrEF.
Okay, let's drill down into the tools we have for these strategies. Starting with rate control, again, we mentioned beta blockers and calcium channel blockers. If those aren't enough, or maybe aren't tolerated, what's next?
The main second line or add-on agent for rate control is digoxin. It works differently, mainly by increasing vagal tone to slow down conduction through the AV node. Digoxin can be particularly useful in more sedentary patients, or as an add-on therapy in patients with HFrEF, because unlike calcium channel blockers, it doesn't worsen contractility. It might even have a mild positive inotropic effect. The downside is that its effect is often blunted by sympathetic activity, so it doesn't work very well to control heart rate during exercise or stress.
And what about our heart rate targets? You hear about lenient versus strict control. What does that mean, and which should we aim for?
Yeah, this changed after the Race 2 trial. Historically, we aimed for strict control, meaning a resting heart rate under 80 beats per minute and maybe under 110 during moderate exertion. But Race 2 compared this strict strategy to a lenient strategy, which just aimed for a resting heart rate under 110 beats per minute. And they found that the lenient strategy was non-inferior to the strict strategy in terms of major cardiovascular outcomes for most stable outpatients with persistent AF.
So for many patients, just keeping the resting rate below 110 is enough.
For many, yes. The lenient approach is often easier to achieve, requires lower doses or fewer drugs, and might lead to fewer side effects like fatigue or bradycardia. We generally reserve pushing for stricter control, aiming for that resting rate under 80 only for patients who remain significantly symptomatic despite achieving the lenient target, or if there's concern for tachycardia-induced cardiomyopathy, where the fast rate itself is damaging the heart muscle over time.
Okay, lenient 110 is usually sufficient unless symptoms persist or cardiomyopathy develops. Now let's switch to the rhythm control toolbox, antiarrhythmic drugs or AADs. The choice here seems heavily dependent on whether the patient has underlying structural heart disease. What about the drugs for patients with clean hearts?
Right, structural heart disease is the key dividing line for AD choice. If a patient has essentially a normal heart, no significant coronary artery disease, CAD, no history of MI, no significant left ventricular hypertrophy, normal EF, then the class-like agents are often preferred first. These are flecainide and propafenone. They work primarily by blocking sodium channels. They're reasonably effective, maybe preventing AF recurrence in 50 to 70% of patients.
But huge contraindications.
It's absolutely critical contraindication.
Yeah.
You cannot use class-like agents in anyone with structural heart disease, especially ischemic heart disease or significantly reduced EF. The CAST trial, decades ago, showed they increased mortality in post-MI patients due to proarrhythmia causing dangerous ventricular arrhythmias, so only for structurally normal hearts.
Okay, class-like for normal hearts only. What if the patient does have structural heart disease, like coronary disease or heart failure? Then we look at class 3 agents.
Yes, if structural heart disease is present, we primarily turn to the class 3 agents. These mainly work by blocking potassium channels to prolong the atrial refractory period. The workhorse here, historically and still the most broadly effective drug, is amiodarone.
Amiodarone is effective, maybe up to 80% prevention, and safe in heart failure.
Correct. It's highly effective, and it's considered safe to use in patients with HFrEF or significant CAD. That's its major advantage. The huge downside, though, is its long-term toxicity profile. It accumulates in tissues and can cause significant problems over time.
What kind of toxicities?
Multi-organ. Pulmonary fibrosis is the most feared, though often dose and duration dependent. Thyroid problems are very common, either hyper or hypothyroidism. Liver toxicity, corneal deposits, skin discoloration, neuropathy. The list is long. So while it's effective, you really need to use the lowest effective dose and monitor patients very closely for side effects if they're on it long term.
A potent drug, but needs respect. What are the other main class 3 options?
Well, there's dronarone. It's structurally related to amiodarone, but without the iodine moiety, so less thyroid toxicity. It's moderately effective, maybe less so than amiodarone. Crucially, though, dronarone is contraindicated in patients with symptomatic heart failure or permanent AF due to trials showing increased mortality in those groups, so its use is more limited.
And then there are sotalol and dofetilide, which have their own specific safety concerns.
Right. Sotalol and dofetilide are also class 3 agents, moderately effective, maybe in that 50-70% range for maintaining sinus rhythm. Sotalol also has beta-blocking properties. Their main issue is the risk of QT interval prolongation on the ECG, which can lead to a dangerous ventricular arrhythmia called torsades de pointe. This risk is increased with kidney dysfunction, electrolyte problems, or interacting drugs. Because of this risk, both sotalol and dofetilide require initiation in the hospital with continuous ECG monitoring, usually for about 3 days, to watch the QT interval and dose adjust safely.
So inpatient initiation required for those two due to torsades risk. Beyond the drugs, we have procedures for rhythm control. We mentioned electrical cardioversion for unstable patients. How effective is it generally?
Electrical cardioversion, or DCCV, is very effective at the moment of delivery. Success rates for restoring sinus rhythm immediately are usually very high, often over 90%, especially if the AF is relatively recent onset. It's fast, reliable. As we said, it's the go-to for instability. The limitation isn't getting them back into sinus rhythm, it's keeping them there. Without addressing the underlying substrate or starting an AED, recurrence rates after cardioversion alone are quite high.
Which leads us to catheter ablation. Its role seems to be expanding significantly.
Definitely. Catheter ablation has moved from being a last resort for drug failures to being considered much earlier, even first line, in certain patients. The main technique is pulmonary vein isolation, or PVI. The goal is to electrically isolate those triggers in the pulmonary veins we talked about earlier. This is usually done using either radiofrequency energy, which heats the tissue, or cryoballoon energy, which freezes it, creating scar lines around the vein entrances.
And who's the ideal candidate for ablation now? Has that changed?
It has broadened. It's clearly indicated for patients who remain symptomatic despite trying an antiarrhythmic drug. But it's also strongly recommended as a primary strategy for symptomatic patients with HFrEF, based on CASTLE-AF. And increasingly, it's being offered as a first-line option, even before trying drugs, for younger symptomatic patients with paroxysmal AF who want to avoid long-term medication.
What are the success rates like compared to drugs?
Ablation is generally more effective than drugs for maintaining sinus rhythm long-term. For paroxysmal AF, depending on the study and definition, you might see 1-year freedom from AF rates anywhere from 60% up to maybe 90% after 1 or sometimes 2 procedures. That's significantly better than most AAs. For persistent AF, it's tougher. The success rates are lower, maybe closer to 50% or 60% at 1 year, and often requires more extensive ablation beyond just PVI.
And the risks? It's an invasive procedure.
It is. While generally safe in experienced centers, there are potential serious complications. The overall rate of major complications is typically quoted around 2 to 5%. These can include cardiac tamponade, bleeding around the heart, stroke during the procedure, vascular access complications like hematoma or AV fistula, and rarely damage to surrounding structures like the esophagus or phrenic nerve or narrowing stenosis of the pulmonary veins themselves. So it requires a careful discussion of risks and benefits.
Okay, let's move to the third pillar. Anticoagulation. This is maybe the single most important thing we do to prevent devastating outcomes, regardless of rate or rhythm strategy, correct?
Absolutely. Anticoagulation based on stroke risk is paramount. If a patient's CHA2DS2-VASc score meets the threshold again, U2 for men, U3 for women, they need anticoagulation. And a really critical teaching point is, achieving sinus rhythm, whether with drugs or ablation, does not mean you can stop anticoagulation if their underlying CHA2DS2-VASc risk remains high. The risk of silent, undetected AF recurrence is significant, and the stroke risk comes back with it. So anticoagulation is usually lifelong based on the risk score, not the rhythm status.
That's a crucial point. Rhythm control doesn't equal stopping anticoagulation if the risk score is high. Now, the agents we use have shifted dramatically, DOACs versus warfarin. Why are DOACs preferred now for most patients with non-valvular AF?
The direct oral anticoagulants, or DOACs, that includes dapicarna, rivaroxaban, apixaban, and edoxaban have really become the standard of care. The main reason is their improved safety profile compared to warfarin, particularly regarding the most feared complication, intracranial hemorrhage. Meta-analyses consistently show DOACs cause significantly fewer brain bleeds than warfarin. Some also show lower rates of other major bleeding, and apixaban even showed slightly better stroke prevention than warfarin in its main trial. Plus, they have fixed dosing, fewer drug interactions, no dietary restrictions, and crucially, no need for routine I&R monitoring. That convenience and safety margin makes them preferred for most.
So, much lower risk of brain bleeds, easier to use. When would we still use warfarin then?
Warfarin definitely still has its place. It remains the standard and really the only well-studied option for 2 main groups. Patients with mechanical heart valves. DOACs were actually shown to be harmful or less effective in this group, and patients with moderate to severe mitral stenosis, which is usually rheumatic in origin. These patients were largely excluded from the major DOAC trials, and the clot risk mechanism might be different, so warfarin remains the recommendation there.
Mechanical valves and moderate to severe mitral stenosis stick with warfarin. Everyone else with non-valvular AF, DOACs are preferred. Can you briefly remind us of the key trial findings for DOACs that established this?
Sure. The landmark trials were key. Aristotle compared apixaban to warfarin and found apixaban was superior for preventing stroke or systemic embolism and caused significantly less major bleeding and resulted in lower mortality. That was a triple win. RAY compared 2 doses of dabigatran to warfarin. The higher dose was slightly better at stroke prevention but similar bleeding overall, while the lower dose was non-inferior for stroke but caused less bleeding. Both doses significantly reduced intracranial hemorrhage compared to warfarin. Rocket-AF looked at rivaroxaban versus warfarin, primarily in a higher risk population, and found non-inferiority for stroke prevention with similar major bleeding, but again, significantly less intracranial hemorrhage. Engage-OFTEMI 48 showed similar results for edoxaban. So the consistent theme across all of them was a major reduction in brain bleeds, which is huge. Pooled data suggests roughly a 50–55% reduction in intracranial hemorrhage risk with DOACs versus warfarin.
That reduction in intracranial bleed risk is really compelling. Now, a common scenario in the hospital is needing to cardiovert someone, but maybe their AF has been going on for a while or we don't know how long. What are the rules around anticoagulation timing in that situation to prevent stroke?
Yeah, this is critical for procedural safety. If the AF duration is clearly longer than 48 hours, or if you simply don't know when it started, you have to assume there could be a clot already formed in the left atrial appendage. The standard approach is to ensure the patient is therapeutically anticoagulated for at least 3 consecutive weeks before you attempt cardioversion. This gives time for any existing clot to potentially dissolve. And then, equally important, they need to continue therapeutic anticoagulation for at least 4 weeks after the cardioversion, because the atrium can be stunned and prone to forming new clots even after sinus rhythm is restored.
3 weeks before, 4 weeks after, if duration is 48 hours or unknown. Is there a faster way if cardioversion is more urgent?
Yes, there's the TEE-guided approach. You can perform a transesophageal echocardiogram, TEE, right before the planned cardioversion. The TEE gives a very clear view of the left atrial appendage. If the TEE definitively shows no thrombus, then it's considered safe to proceed with cardioversion immediately without the 3 weeks of pre-anticoagulation. However, and this is important, even if the TE is clear and cardioversion is done, they still need that minimum of 4 weeks of continuous anticoagulation afterwards to cover the atrial stunning period.
So TE can bypass the before period, but not the after period. What about that difficult group of patients who have a high stroke risk, Chad's VASC score is high, but they have an absolute contraindication to being on any long-term anticoagulant, maybe recurrent severe bleeding? Is there anything we can offer them?
Yes. For that specific challenging population, left atrial appendage occlusion, or LAAO, has emerged as a really important option. We know that in non-valvular AF, over 90% of the stroke-causing clots originate in the left atrial appendage, which is this little pouch off the left atrium. LAAO devices, like the Watchman device, for example, are delivered via catheter and are designed to physically seal off the opening of the appendage, preventing any clots formed inside from escaping into the circulation.
And is it effective?
Clinical trials like PROTECT AF and PREVAIL compared LAO mostly to warfarin. They showed that LAO was non-inferior to warfarin for preventing stroke or systemic embolism over the long term, particularly ischemic stroke. While there were some procedural risks up front, the long-term rates of disabling stroke and bleeding, especially hemorrhagic stroke, tended to favor LAO. So it's a very reasonable alternative for patients who truly cannot tolerate long-term anticoagulation due to prohibitive bleeding risk.
Okay, LAAO as a non-pharmacologic alternative for high bleed risk patients. Let's touch on a few special populations before we wrap up. Back to heart failure. HEF, we know ablation is good. Beta blockers are the rate control drug of choice.
Yeah.
Any other key medication points?
Just to reiterate the negative point, absolutely avoid non-dihydropyridine calcium channel blockers, diltiazem, verapamil, in HFrEF due to their negative inotropy. It's a critical safety issue. Stick with beta blockers, maybe add digoxin if needed for rate control, and strongly consider rhythm control, preferably ablation, for symptom and outcome benefits.
What about older adults, say over 65 or 75? Age is such a big driver of stroke risk.
Yes. Age heavily weights the CHADS VASC score, so anticoagulation is almost always indicated in older adults with AF, even though their baseline bleeding risk is also higher with age. This is where the DOACs really shine, because that significantly lower risk of intracranial hemorrhage compared to warfarin is particularly beneficial in the elderly who are more prone to falls and bleeds. So DOACs are definitely preferred. On the other hand, older adults are often more susceptible to side effects from antiarrhythmic drugs and might have more comorbidities. So unless they are very symptomatic or have tachycardia-induced cardiomyopathy, a rate control strategy is often favored over rhythm control just from a risk-benefit standpoint for the rhythm strategy itself. And crucially, you have to be very careful with DOAC dosing in the elderly, paying close attention to renal function, as many are renally cleared and doses often need adjustment based on age, weight, and creatinine.
Right. Dose adjustment for DOACs is key in the elderly. And the very unique situation of AF during pregnancy. What are the main considerations?
Pregnancy is really complex. Medication safety for the fetus is paramount. If the patient is unstable, DCCV, electrical cardioversion, is considered safe throughout pregnancy and is the first choice. For rate control in a stable patient, beta blockers are generally used, specifically metoprolol or labetalol. Atenolol should be avoided as it's been linked to fetal growth restriction. Digoxin can also be used. Anticoagulation is the trickiest part. Warfarin carries a risk of embryopathy, especially in the first trimester, although the risk might be lower with very low doses, like AV-nodal. Low molecular weight heparin or unfractionated heparin are generally preferred, particularly around the time of delivery. DOACs are currently contraindicated throughout pregnancy due to lack of safety data. It often requires careful management by a multidisciplinary team.
Okay, very specialized management in pregnancy. Finally, let's look beyond the acute drugs and procedures. There is growing evidence that long-term success in managing AF requires more specifically aggressive risk factor modification.
This is absolutely critical and maybe the most important evolution in AF care over the last decade. We now understand that managing the underlying risk factors is not just complementary, it's essential for reducing the burden of AF and improving outcomes from any therapy, whether it's drugs or ablation. Hypertension is probably the single biggest modifiable risk factor. Intensive blood pressure control significantly reduces the risk of developing AF and its progression.
And what about weight management? The legacy trial results were quite eye-opening there.
Yes, Legacy was incredibly impactful. It studied overweight or obese patients with AF and looked at the effect of a structured weight management program. It found that patients who achieved and maintained significant weight loss defined as 10% or more of their body weight had dramatically higher rates of arrhythmia-free survival, up to a 6-fold increase compared to those who didn't lose weight. And just as importantly, they found that weight fluctuations yo-yo dieting actually negated the benefits. It really underscored the need for sustained weight loss and lifestyle change.
Sustained weight loss makes a huge difference. What other lifestyle factors are key for long-term AF control?
Several others are crucial. Treating obstructive sleep apnea, OSA, is non-negotiable. Untreated OSA drastically increases AF recurrence rates, especially after ablation, so screening for it and ensuring good CPAP adherence if diagnosed is vital. Smoking cessation is important. Reducing alcohol intake, even moderate amounts of alcohol, have been clearly linked to increased risk of AF episodes. And regular moderate intensity exercise is generally beneficial for cardiovascular health and can help manage other risk factors like weight and blood pressure. It's really about a comprehensive, integrated approach. And we're seeing that multidisciplinary AF clinics that help coordinate all these aspects, risk factors, anticoagulation, rhythm strategy, patient education, tend to achieve better adherence to guidelines and better patient outcomes.
So managing AF long-term is really about managing the whole patient and their cardiovascular risk profile. Okay, to try and pull all this together from our deep dive. Managing AF in the hospital today really seems to hinge on a few key things. First, aggressively look for and fix those acute triggers. Second, make a personalized choice between rate and rhythm control, but with a clear lean towards early rhythm control now, especially for newer onset AF or those with heart failure, thanks to trials like ESAFNet-4. And third, be rigorous about stroke prevention with anticoagulation, using CHADS-VASc and strongly preferring DOACs for most.
That sums it up well, and the big mindset shift is moving away from just accepting rate control as good enough for everyone. The evidence is pushing us towards intervening earlier with rhythm control when appropriate, and just as importantly, doubling down on comprehensive long-term risk factor modification like the weight loss impact seen in Legacy. These are the strategies that seem to actually change the natural history of the disease and improve those heart outcomes we care about.
So let me leave you, listener, with a provocative thought based on where the field is heading. We've seen catheter ablation become more effective and safer over time. We know it's generally superior to antiarrhythmic drugs for maintaining sinus rhythm long-term, and it avoids the systemic toxicities of those drugs. So the question is, should catheter ablation be moved up even further? Should we perhaps be considering it first-line therapy for almost all symptomatic patients with paroxysmal AF, maybe even before trial medications, especially if they have other cardiovascular risk factors? That's a debate happening right now, and how guidelines evolve on that point could really reshape our approach to AF management in the coming years.